Welcome back. I would like to invite Aissami. So Dr. Aissami Abdou has worked in operations management, coordination, and public health with different NGOs, including MSF and ICRC, across humanitarian crises in Sudan, the Democratic Republic of Congo, Afghanistan, Mali, Ethiopia, Somali region, Niger, should I say, Guinea, Sierra Leone, Cameroon, Benin, Nigeria, Chad, and Belgium. Experience in scientific reporting and publications, Dr. Aissami Abdou holds a PhD in social epidemiology from the University of Antwerp and is currently the operations coordinator at MSF Operational Center Brussels for Mali, Nigeria, Benin, Guinea, and Sierra Leone. Today, Dr. Aissami Abdou will discuss what the observed gaps are related to providing humanitarian assistance to older people from the perspective of medical operations in Médecins Sans Frontières.
Thank you very much, Ilvon, and hopefully you had a nice coffee. My own is going to try to give you a perspective on the real operational gaps we see on the ground, at least from the perspective of the region I'm in charge of, which is Western Africa. I will start by recalling a statement made by Ahmadou Hampateba by then, who was a Malian ethnologist. He was represented his country just after independence to UNESCO session. He said, in Africa, sorry, oh, that's great. Thank you. He said, in Africa, when an elder dies, is a library that burns down. It all tells you actually the place elderly has in some of these contexts, and specifically in the African context, and we'll come back to it as in a while. So, and I would like to start also quickly by telling you a story from Mali, where I was coming back 3 weeks ago. Before telling the story, very quickly, I would like to just give you a glance of the context of Mali, without going into more details. Mali is a country you can see here in the West Africa region, a country affected by a conflict for the past decades, actually, more than a decade. There is an ongoing conflict going there. I won't go into the details of the conflict, but for instance, when you look into the accolade specialized, in data aggregation and conflict, they say the West Africa region today is the region with the highest burden of genetic activities related to jihadists, IS and ACME related groups. When you see the cluster around Burkina, Mali, and Niger, so there's an ongoing conflict there. There was the multidimensional UN mission. It was the first UN mission, multidimensional, that was deployed there. It was a test also. It was more than 1 billion USD a year. It was 15,000 soldiers from many countries, and on record, it was the deadliest UN mission. So there's an acute ongoing conflict in that country. There is a disease burden in Mali, unlike, sorry, computer says no? Just go to the next. I can continue maybe before the computer agrees. So, that was the conflict without going into the details of it, but the region, Mali also, participating in the West Africa region has, yes, thank you. It has, can you go to the next one, please? Yes, the country has also, as being part of the West African Sahel region, has the highest worldwide disease burden. This is based on the WHO data. When you see the darkest area there, the daily, the neonatal diseases, the maternal mortality, when you consider the disease burden, Mali belongs to the region of the world with the highest, disease burden. When you see the medical workforce, there is the density, of the medical workforce. The Mali belongs to the region with the lowest medical workforce. When you go to issues like, demography, fertility rates, you see there also Mali is one of the countries of the world with the highest fertility rate. I usually give the example of Niger, my own country. We are actually having the highest world fertility rate. On average, a woman is having 6.2. My own mom is having 9 kids. So demography in this region is key, and I will come back to it and make the link with elderly population. So the region will also affected with climate vulnerability, poor governance, poverty. So it's a whole, what I personally call the Sahel cocktail. Mali is really part of this region affected by multidimensional vulnerability and crisis. Coming back to the story that I was coming back from Mali 3 weeks ago, I went to a village where MSF worked, for almost a year. What happened there is that recently, due to geopolitical tension and the conflict dynamics, French has to leave the country and the Russians has to come in. So when Russians came, they killed many people. This was off record. Unfortunately, civilians are trapped in this crisis. They are being killed by the government forces. They are being killed by international forces. They are being killed by opposition forces. So Russians, they came in a village. Before even they arrived to that village, MSF was working next to that village. Almost everyone flew because really there was information about prior villages where they went. So everyone flew. And the head of the village, who was the elderly, along with 6 others, people, they stayed because for them also it's dignity issue that they have to stay there. Like they are really the one representing the village. They are the village council, the elderly, and they are all killed. They were killed because, unfortunately, there they can't go for many reasons. They can't flee, but also for them, like they are the village. They are the source, and they have to stay. And unfortunately, they were all killed. When we start working in this village, the community told us that the MSF doctor is the first doctor they saw for the past 7 years. Just to give you a bit of the context on this. So coming down to the observed gap, we see then, for me, the gaps we see on the ground, they are of 2 categories. They are what I would like to call the mindset gap, because there, the situation also on the ground is that historically we have a mindset of emergency. MSF basically works most of the time during conflict-affected area, during epidemics. We come and we deploy in emergency. So we have the gap that the mindset, the way is a kind of subconscious bias, is a mindset gap that the way we came, we look into things very quickly. We have the so-called emergency preparedness plan. We prepare for things. We prepare for measles. We prepare for vaccination. We also, and the way our mind is set, we look into the so-called vulnerable group. And historically, we look into women, we look into children. So there is really a mindset gap on addressing the elderly. We usually, even on our data, we disaggregated under 15 and above 15. We have the methodological gap because the tools we have, most of the time, the tool we do assessment also are preconceived, looking into gaps related to women and children. We have also a cultural gap. MSF was born in Biafra, I recall it, but there is in Africa, that's the reality. When you see the map also, Amnish showed with the majority of MSF projects, they are still located in sub-Saharan Africa. But then the resources, the funding, the knowledge is all coming from the West. So there's also that cultural gap dimension on also grasping what's going there on the ground. Then finishing by the operational gaps. Let me give you the example of nutrition. In 2023, MSF did the biggest response of its history, nutritional response. 1/3 of that response was done in Nigeria. This has aggregated data from all MSF OC. So we treated 200,000 ITFC below 15 years children. We treated almost less to 600,000 also from 0 to 14 years. But the situation is that this is nutritional response. These are not really community-based intervention. For instance, ITFC are children we treat inside hospitals. They're hospitalized. Children malnourished with medical complication. Even the ATFC, they are treated within structures. So it's not even community-based intervention. But this, we strictly define age. We say we go from 0 to 14. But take the example of the so-called ITFC, this 200,000. They are children hospitalized. On average, they stay a week within MSF hospitals. But then we don't even look into the malnutrition of the mothers, because also the malnutrition drivers, when we look at them, they affect both children and elderly. We're not even talking about elderly, even people above 15, because the malnutrition is due to conflict, is due to climate change, is due to purchasing power, is due to poverty. So there is even no reason that the drivers, affect let's say elderly and non-elderly, but we did the choice to just go for young population. So this is also something really key on the malnutrition. We see a very critical gap there because we just decide to look into the segment of population that is from 0 to 14, and we forget all over. So this is really a very key gap. The graph shows you for the past 16 years how we grew up on doing malnutrition response, but then still we stick to this age criteria. We have also this you can see here out. This is what we call mutual accountability report. As MSF, we do every year. We compile out all our activities. We try to do graphs by epicenter and trying to show what we have done. You see the activities we have increased maternal health, nutrition, but you see the activities, or let's say the medical thematics where we didn't do a lot, we decreased. We have the NCD, we have diabetes, which are affecting most of the time elderly population. So there's also a critical gap on the non-communicable disease because we don't invest there and we don't look at that specific segment. So yes, on operation is beyond nutrition, mental health. Actually, within that report, you can see that MSF has done roughly around 2 million mental health consultation. And today, MSF is the first provider of mental health responses in humanitarian crisis. But still there also, we really have a gap of looking specifically at the elderly population. Ophthalmology, we 1 month ago, MSF team went into a village in Mali. When they arrived, almost the whole elderly population of the village come and told the MSF team, we have ophthalmic problem. But we were shocked because before going to that village, we usually have what we call the e-prep scenario. We took drugs, we get ourselves ready as much as we can, but we do it based on vaccination, we do it based on malaria, we do it based on malnutrition, but we were never ready for that. We didn't even think about that. So it was a shock for also a group of elderly population to come and to tell the MSF team, look, this is now our needs, because this is, and this is happening in Mali. And you are very right, you talk about situation in Ukraine, elderly population and elderly needs. But what's even more striking in countries like Mali, where last time the UN representative in Mali told me that the entire humanitarian response plan, which is about 900 million, got funded only at the level of 10%. So 10% of the overall required, means to address the humanitarian needs, which even themselves don't factor enough elderly population. Only 10% was recovered, which is not the case for other crises. We have other crises in other parts of the world, but at least they have, a certain level of attention and funding. But then we have already that problem of insufficient funding. Then chronic disease, as I said, and the comorbidities, because also the real situation on the ground is that elderly have comorbidities. There is also the final concept of a risk multiplier, because unfortunately elderly, they also have, this risk multiplier dimension with gender, disability, and LGBTQ that has been already discussed by other smokers. So my 3 final takeaway message for gaps, I think we have a mindset gap, we have a methodological gap, and we have a cultural gap, at least from what we see on the ground. Then also in the operational gap, we have a gap in nutrition, we have a gap on mental health, and we have a gap on NCD. And don't forget also that in Africa, when an elder dies, is a library that burns down. So we should take care of the intergenerational knowledge managed by elders. At the end of the day, a recommendation is that during humanitarian crisis, we should listen to elderly. We should conduct more research, and this Elburg, I think she paved the milestone we should build on. We should conduct more research, and we should also include elders in humanitarian media communication. That's it from my side. Thank you.
Beautiful. Thank you so much. I think we have time for one question. Anyone? I saw you working, no? Sorry.
I think from the utilitarian perspective, we need to value how precious a library is. That's something that we tend to ignore when we assess the value of lives or the value of human beings. We don't realize that experience and time has actually been accumulated, and that is extremely valuable.
Thank you. The metaphor of a library is also one that sticks with me because, well, maybe also because we're all book people and I like reading likely. But a library has multiple functions indeed. But a library is also something that ideally is publicly protected through structures and through different ways of maintaining and curating that knowledge. So one of my questions is, in addition to libraries being part of people's head, what other forms can we identify that the knowledge that is in those people's minds and wisdom is saved in a different way? Also because life is ending for everyone at some point. So this curation of the knowledge within communities, I'm really curious about your thoughts. And I do want to also recognize my colleagues working on narrative ethics and narrative medicine for also, yeah, there are different fields that work a lot on collecting of stories. That inspired my question, but I'm really curious about your thoughts here.
Yes, so I don't know. I think, sorry, I don't know, but I think the concept of knowledge and library is also because we are living in a digital era. You know, we are digitalizing libraries today, but it's at least how we can conserve it. You know, how we can make it longer, because I think that's one of the reflections we can take out. It's our old classical books library today. They are being digitalized. You know. So with a mindset, I think, with an idea of getting them longer, of taking, of conserving them. So I think this is one of the also one of the things we can take out of the African Malian proverb and wisdom is that, yes, elderly, they are libraries. So if we can do either in humanitarian setting or outside humanitarian settings, if we can offer them medical, service, if we can make their life being longer, we conserve that knowledge and that wisdom. I think this is how I can see it.
Thank you so much.